First of all, I'd like to thank the scientific committee for having selected our abstract for this session. So our work, it's an international clinical trial that we've performed over several years now, and we are updating the interim results on the outcomes for relapsed and refractory patients with high-risk neuroblastoma. I am here presenting this abstract on behalf of my co-authors and principal investigators of all the institutions that have participated in this trial. And I don't need to remind anyone in this audience what high-risk neuroblastoma is and how important it is in our practice. Regularly, 50% approximately of all the neuroblastomas present as high risk, with bone and bone marrow metastases as the most common sites for disseminated disease, and most likely a reservoir of cells to keep spreading and disseminate, and mechanisms of resistance occurring most likely also in this site of metastasis. Patients who do not respond to initial treatment, a frontline treatment, you all know, have a much worse prognosis, and alternatives, real alternatives therapies for these patients are really lacking. Naxitamab is a humanized, the humanized 3-FET antibody. It's an anti-GD2 antibody that it's well known to act against neuroblastoma through inducing an ADCC and a CDC. Those are mechanisms well reported and well studied. And the trial 201 was designed to study the effect of Naxitamab plus GM-CSF in patients with relapsed refractory high-risk neuroblastoma with residual disease only in the bone and or bone marrow, no soft tissue, no CNS disease. We report the results of this pre-specified interim analysis. The data cut off for the trial was December 31st, 2021. We're going to be presenting data regarding the population efficacy set of data labeled here as FAS for 52 patients, and safety population, or SAF, for 74 patients enrolled in the study. This is a pivotal phase 2 with a primary objective of evaluating the objective response rate of Naxitamab plus GM-CSF as per the International Neuroblastoma Response Criteria, NRC. Long-term secondary effects, of course, include evaluating progression-free survival and overall survival of these patients at 3 years, which we haven't completed. Efficacy was evaluated, this is important, by an independent committee of pathologists and radiologists, independent of the PIs of the study. And assuming an objective response rate of 45% CR and PR, a sample of 37 patients was considered sufficient to ensure a 90% power to exclude an objective response rate less than 20% with an alpha level of significance of 0.05. As you may know, the schema of treatment, it's intended to be outpatient. It's a backbone of 10 days, subcutaneous GM-CSF, 5 days at 250 micrograms per meter square per day, mostly provided by the families, and 5 following days of GM-CSF, also subcutaneously injected at 500 micrograms per meter square per day. On those second 5 days of the schema, 3 doses of antibody intended to be 3 milligrams per kg per day, and 3 doses, usually Mondays, Wednesdays, and Fridays, injected over 30 to 60 minutes, first day over 60 minutes. This is the one cycle, and patients will be evaluated every 2 cycles. Subsequent cycles are administered every 4 weeks. And if the patient reaches CR or objective response PR, followed 5 additional cycles. The eligibility criteria for this trial: high-risk neuroblastoma above the age of 1 year, with evaluable disease only, again, in the bone and bone marrow, with no active progressive disease, so you have to prove the patient is at least stable, no systemic treatment, either chemo or immuno, 3 weeks before entering the first dose of GM, and no prior treatment with Naxitamab. 2 subsets of patients entered: primary refractory disease, meaning incomplete response to initial therapy, which must include at least 4 cycles of multimodality multi-drug chemotherapy, and less than 18 months since initiation of chemo diagnosis. And the relapse subgroup, which is patients who had either relapse or had progressive disease that had incomplete response to also whichever salvage therapy was applied. Incomplete response to this treatment with persistent bone and bone marrow disease. This is the clinical characteristics of this set of efficacy subgroup of cases, 52 patients, with a split, almost split female and male ratios. As you can see, we have a 56% of Asians, mostly because the contribution of our center has contributed mostly patients coming from China. So this is also, that's why most people asking why Asians. But that's the reason. Large majority of patients are stage 4, as expected, with 56% with only bone, 40% with bone and bone marrow. You can see median baseline Curie score, which is an important measure of the burden of disease, is a median of 3. And primary refractory and relapse subgroups, 50% each. As expected, everybody had received chemotherapy. Majority have received, had surgery prior, and a subgroup of cases had already had high-dose chemotherapy and transplant, ASCT, and a quarter of patients had received prior anti-GD2 antibody. No Naxitamab, dinutuximab family of antibodies. This is the overall response rate that we are reporting: 50% objective response rate, 38% complete remissions, 12% partial remissions, with median cycles of two cycles to achieve objective responses. So basically, you know fairly rapidly whether the patient is going to objectively respond or not to this schema. The median duration of response, it's at least 6 months. We have not been able to calculate the extent because 20 out of the 26 patients that objectively responded still having an ongoing response. Analysis of the different subsets, as you can see, the 20% bar, which is the limit of our statistical confidence interval. You can see consistent response in almost every subgroup, primary refractory and relapse. Relapse a little worse than primary refractory. Bone marrow and bone, also consistent responses, as well as bone only. The cutoff of 3, Curie score of 3, or less than 2, it doesn't make a difference. And having used prior Naxitamab, prior anti-GD2 antibody, it just doesn't seem to be making a major difference, although the numbers are still low. About disease control rate, which includes CR/PRs, mixed responses, and stable disease, whatever the time is, when the investigator reported stable disease, is 79%, including both sets, primary refractory as well as relapse subgroups. Patients responding in the bone marrow and the bone compartment also similarly with Curie score not making a difference between these more than 3 or less than 2 Curie score. prior use of Naxitamab seemed not to make a difference in the way they responded to Naxitamab challenge. What about the adverse events? This is a long list of all the patients who had, all the adverse events reported, at least in 10% of the cases. In the central column, all related adverse events. And on the next column, you can see grade 3s or more adverse events, at least in 10% of the individuals treated. As you can see, vast majority of patients had pain, hypotension. It's almost for everybody to have a grade 1 or grade 2 hypotension, as well as urticaria and bronchospasms quite frequent. Grade 3s and in these categories are also important. There are few grade 4s and no grade 5 toxicities in the trial. Important because of these grade 3 adverse events are quite common. How long do they last? Well, majority of these grade 3s last for less than 6 hours. That's the reason why we can keep up on our intent to be an outpatient treatment, even though they might have a grade 3 adverse event. This is important also. Out of the more than 1,200 infusions that we are evaluating, 93% had been performed as an outpatient, and 99% were completed as aimed for the whole dose of 3 milligrams per kg. Only 1% of all the infusions, total of 13 out of the more than 1,200, did not complete the intended dose. This is the list of the severe adverse events that prevented for the patient to complete the treatment as expected. As you can see, anaphylactic reactions in 3 cases, PRES in 1 case, respiratory depression in 1 case, severe urticaria and 1 severe hypotension. Those were the major side effects that prevented these patients to complete the planned treatment. So in conclusion, Naxitamab plus GM-CSF provided a significant and clinically relevant outcome in patients with relapsed refractory bone marrow disease with an objective response of 50% confirmed by external reviews, with a CR of 38% and a disease complete response, or disease control response, 79%. At last assessment, 20 out of the 26 patients with CR/PRs had an ongoing response, so we could not analyze the end of the confidence interval. Efficacy of Naxitamab with objective responses was demonstrated across all the relevant subgroups that were analyzed. And the Naxitamab adverse events were manageable with early recognition, timely intervention, and skilled team. That it's what can provide the patient the best safety records. And Naxitamab and GM-CSF addresses a significant medical unmet need, as you may recognize how difficult are for these patients to treat. Thanks for your attention.